A very good morning to everybody. I'll be the opening batsman for today. At the outset, I thank the organizers for giving me this opportunity. So in the next 20 minutes or so, I'll try to demystify this AKI-CKD conundrum. The slides. Forward. Pointer. It's okay. No, చూసుకుంటాను. That's okay. So before going into the topic per se, let me introduce few small details that we all know. That the number of nephrons that we are going to have is set at birth, and it starts declining with the age starting 25. Parallelly, our metabolic activity also declines, so that at the age of 70, somebody who is healthy with only half of the original nephron number feels very well. Any loss of nephrons beyond the normal aging process, or if somebody is born with a lower nephron endowment, their renal lifespan is going to go down. Now, nephron loss is very difficult to appreciate in clinical practice. Recovery in renal tissue does not mean regeneration always. We have a very specific mode of recovery called as polyploidization, which means they increase in the size and in the functionality. This is a very highly evolutionary conserved mechanism for well-differentiated cells with a very low turnover. The other concept that I would like to introduce is something we all know called as the renal reserve. So if we look at that, the baseline GFR is what we actually have. And then whenever there is a stimulus like pregnancy or an infusion of protein, there is always a tendency for the GFR to go up. So the max GFR and the difference between the max and the normal GFR is called as the functional reserve. And this is very important when it comes to the context of acute kidney injury. So I'll start with two patients. These are embodiments of typical AKIs that we see. I'm not going to go through these slides for want of time. So here is a 42-year-old poorly controlled diabetic obese lady with 3 episodes of AKI. Two factors, one probably a PIGN and the other is an NSAID. And then later went on to have 2 more episodes of AKI, and a year after the first episode, her creatinine is 0.7 milligrams per deciliter, but she has some amount of proteinuria. The second patient is a 69-year-old female with 3 years of hypertension, so you can go through the slides. Accidentally detected high serum creatinine, and then it never settled down to below 1.3. Now we waited for 6 months. Finally, we did a biopsy, and biopsy came out as mild chronic interstitial nephritis. So this will teach us a lot in what we have to do in acute kidney injury. So what is conventional wisdom? Acute kidney injury and chronic kidney disease are 2 different clinical entities. This is what we are taught. Survivors of acute kidney injury tend to do well with complete recovery of renal functions. You all will agree that this is what we were all taught. And then the moment the creatinine comes down to normal, we say we discharge from nephrology services because we feel that we don't need to follow them up. And most of the episodes of AKI is forgotten unless somebody is requiring dialysis for that particular episode. But what does physiology teach us? It's very clear that healing process can never be 100% perfect. And this is especially so if the injury is severe. And so it is always plausible that acute kidney injury can lead on to chronic kidney disease. Now, if you look at it, the lifespan of the kidney is always more than the lifespan of the human being into which the kidneys are there. Now, the effect of AKI in the long term depends upon when the acute kidney injury has occurred, whether it is at an older age or whether it is at an younger age. And then it also depends upon what is the nephron endowment. Can you ask them to see whether this thing is visible? Yeah, I think it's here. So what is the problem that we have? We have an AKI at one hand and CKD at the other hand. Both of them are public health issues. AKI causes a significant amount of mortality. The cost of managing AKI is significantly high, and neither of them have a very specific treatment. So the question is, if AKI is a risk factor for CKD, then I think we are going to add a lot more to the chronic kidney disease burden. Just to highlight this, in the Western world, it is about 2100 cases of AKI per million population. So mathematics will tell us that around 300,000 cases of CKD are added every year because of acute kidney injury. And this is going to increase year on year. I'll just skip these two slides because I think this is something we all know. But it was only in the 1950s that people started looking at what happens to patients who had an AKI in the long term. So the first paper in 1952 said 3 out of their 14 patients whom they followed up, could follow up long term, had a creatinine clearance of less than 80 mils per minute, and they attributed it to scarring or vascular damage. 4 years later, we had another paper which said 6 out of 16 had an inulin clearance of less than 70 mils per minute. So they said that an episode of ARF will result in probably more chronic damage than what we actually expect. There was a lull between 1960s to 2000. No major papers in terms of long-term follow-up of acute kidney injury. In the first decade of this century, we had these papers. I've just taken few of these papers. Look at it, 72% had documented CKD within 2 years of AKI. 50% had CKD within 3 years of AKI. And then 50% did not recover renal functions at all. And quite a bit of them were dialysis dependent. So then came a systematic review. So they could find only about 13 papers which could fit in this systematic review. And then look at it. An episode of AKI increases the risk of developing chronic kidney disease tenfold and the risk of developing end-stage kidney disease threefold. Now, the higher the serum creatinine, peak serum creatinine during the episode of AKI is going to tell whether somebody is going to develop CKD or not. And on the other side, the number of episodes of AKI. The more the number of episodes of AKI, the higher the chances that they will develop chronic kidney disease. So what does it tell us? There is some threshold. We are not able to find out what exactly is that threshold, and that is going to differ between an individual to individual. Once that threshold is crossed, then the course of AKI gets altered and it becomes a chronic progressive disease. Now the same is if somebody with AKI requires dialysis, then there is a 28-fold increase in the risk of developing stage 4 or stage 5 CKD in the ensuing years. So this prompted the NIDDK to start a prospective study to look at what really happens to these people who have AKI in the long term. So they followed around 770 people with AKI and similar number without AKI for a period of 3 years, and then they found that there is a higher incidence of CKD in these people, and if somebody has a renal dysfunction prior to that AKI, then they progress faster to end-stage renal disease. Of course, they do have all these cardiovascular events and mortality. This is the graph which says that the chronic kidney disease incidence is higher in those who develop an AKI than those who do not. And similarly, the disease progression is higher in those who develop an AKI. So far we have discussed about retrospective studies, and these are clinical studies. Do we have any report on biopsies in AKI? The problem is we don't have, because we seldom biopsy people with acute kidney injury. And even if we do biopsy, we biopsy them in the recovery phase rather than in the injury phase. Now, most of these effects of AKI, they tend to be there in the outer medulla. We tend to biopsy the cortex. So that is why we don't get much of information about AKI in all these people. We still use serum creatinine as a marker of functional recovery, and we know that it is highly insensitive. Lot of biomarkers are available, and they are not standardized, and they are not available for routine clinical use. This is the list of biomarkers that have been tested. But the final statement is none of them have failed to elicit a troponin-like response for an acute myocardial infarction. None of them are truly specific for acute kidney injury, and early detection does not improve the outcome of acute kidney injury. And these are the few markers which were found to be useful in these two studies. So an early detection using a biomarker can improve prognosis only by a better risk stratification and the use of an appropriate therapy, which is unfortunately not available for AKI and also for CKD. So let us see what exactly happens after an AKI. So we all know that there is going to be an imbalance between an oxygen supply and demand. This is going to cause an hypoxemic and oxidative stress that results in endothelial injury, immune activation, and inflammation. That will cause an interstitial edema and vasoconstriction, and this is a self-perpetuating event. It will go and cause further hypoxemia and oxidative stress. But then the outcome will depend upon the residual renal function, which I said earlier, and the repair capacity, which means the nephron numbers that somebody has at the time of the insult. So we divide the recovery as an adaptive repair and a maladaptive repair. So we all know that there is a tubular injury and there is a vascular injury, and this is going to cause either scarring on one side if it is a maladaptive repair, or it is going to get back your so-called normal renal functions if it is an adaptive repair. So this is exactly what it looks like. The right top is the normal kidney, that is after the injury, and then this is finally after a adaptive repair. But this is exactly what happens when there is a maladaptive repair. Irrespective of the cause of an acute kidney injury, this is what is going to happen. You will have organal damage, you have cell cycle arrest, you have EMT, apoptosis, ferroptosis, you have a lot of fancy names now. And then there is matrix expansion, inflammation, and there is capillary rarefaction. And all of these things will result in scarring, which is basically chronic kidney disease. So essentially the triad, the actual injury is not what is going to cause your chronic kidney disease. It is this particular triad: a vascular insufficiency, glomerular hypertension, and interstitial fibrosis. This is a self-perpetuating mechanism. It will dampen repair. It will cause progressive fibrosis. So we can very well compare acute kidney injury with aging, especially the maladaptive variety. The only difference here would be that there is going to be myofibroblast proliferation when there is an acute kidney injury, and that is facilitated by secretion of profibrotic factors. Now, follow-up of patients who suffer AKI, I think we have a very long way to go. Look at this: 30 days after discharge from hospital with an episode of AKI, only a dismal 12% are being followed up by a nephrologist. The remaining 3/4 are being seen by primary care physicians. I always compare acute kidney injury with acute myocardial infarction. When we look at it, the diagnosis of acute myocardial infarction, in addition to ECG, we started using SGOT, then LDH, then CPK, then CPK-MB, and then TROP-I, and then now people use TROP-T. But on the other hand, when we look at acute kidney injury, right from day one till today, it is serum creatinine, in spite of knowing that serum creatinine is a highly insensitive marker. But it does not stop with that. Let us look at follow-up of AKI survivors by a nephrologist vis-a-vis follow-up of a myocardial infarction survivor by a cardiologist. Same thing. It's only 12% nephrology follow-up for AKI compared to a 76% follow-up of acute MI by a cardiologist. So basically, the least we can do to our patients is to continue to see them so that we can identify those who are going to develop chronic kidney disease and try and institute retardation of chronic kidney disease in all these people. So I see acute kidney injury and chronic kidney disease as an interconnected syndrome. On one side, you have very similar risk factors. On the other side, we have more or less similar outcomes. And acute kidney injury predisposes to chronic kidney disease, and chronic kidney disease itself is a risk factor for acute kidney injury. So I don't think we can separate both of them in most instances. So the message is that AKI is not as benign in terms of long-term outcome as we had been thinking. It more often than not leads to chronic kidney disease regardless of the cause of AKI. There are certain modifiers like severity, frequency, age, comorbid illnesses, etc. We are now understanding the mechanisms of maladaptive repair more clearly. Protocol biopsies in AKI is going to be risky because we know native kidney biopsy is riskier than the transplant kidney biopsy. Long-term nephrology follow-up is the least that we can do to all these patients. The role of biomarkers as of now is still questionable. For me, the most important point is, do undetected episodes of AKI in the community lead on to CKD? Is it increasing the burden of CKD for us? It's a moot point, I think, can be debated. So the topic in the future should not be AKI-CKD conundrum. It has to be AKI-CKD continuum, because that is what we actually see in most of the cases. And this is the pictorial representation of what I had spoken in the last 15 minutes or so. And thank you very much for your patient hearing, and this is where I practice.